Um, I hope you could have a very useful webinar this afternoon. As everyone knows, for everyone who's come to this meeting, perhaps everyone knows that we are going to discuss adult ADHD. Um, I just like to mention that this presentation, um, I mean the whole lectures, the multiple lectures we have, um, is most useful for those who have some basic understanding of ADHD and its presentation in adulthood. We are not covering some basic features and presentations. Um, so we all assume that everyone knows some basic characteristics of ADHD, and we are going to talk about some, perhaps some of the most sophisticated and perhaps controversial aspects of ADHD. Uh, those are um, perhaps um, concepts and ideas most useful for people in the academic settings. I hope everyone has some understanding of the basic ADHD presentation, and we could have a very useful discussion. Um, I start off by covering some of the recent and still controversial topics regarding adult ADHD as it correlates with inattentive symptoms. As we all know, we have two basic dimensions in ADHD, both in childhood and adulthood. One cluster of symptoms, we call it inattentive symptoms. The other cluster is called hyperactive slash impulsivity, or hyperactive impulsive symptoms, cluster of symptoms. Today I'm going to focus on inattentive symptoms in ADHD uh, and in adult ADHD in particular, and some of the recent new thinking about how we classify and organize and think about those inattentive symptoms. The title is Mind Wandering, Sluggish Cognitive Tempo, which is rather a new concept, and Inattentive ADHD. Um, there is a history to every disorder we classify in DSM, including ADHD. And as I mentioned briefly, we have two cluster of symptoms: inattentive symptoms and impulsivity, hyperactivity symptoms. Um, in inattentive dimensions or inattentive symptoms dimension has more back and forth in terms of how to classify it, how to group it with other symptoms, and there is more controversy about it. I just put some of the controversies here. In DSM-3, uh, as we know, we had ADHD and also we had ADD. And for ADD, what we meant back then was just the presence of inattentive symptoms. They changed it in DSM-3R and then DSM-4 and also now DSM-5. In DSM-4, in DSM-3R and DSM-4, we had three subtypes. The first subtype was ADHD inattentive subtype. The second subtype was ADHD hyperactive impulsive subtype, and the third subtype was combined inattentive plus hyperactive/impulsive. In DSM-5, we got rid of subtypes, and now we have predominant presentation, which could change over time during different stages of life. So, for instance, you could have a hyperactive presentation during childhood, and then in adolescence, you could have hyperactive presentation. In adulthood, you could have again inattentive. So these constant changes in how to organize and think about inattentive symptoms perhaps point to a very important underlying confusion, which I would like to touch on some of the important issues. In recent decades, there have been some interesting, sophisticated studies. Most of them are sophisticated neuroscience studies looking at mind wandering and its correlates in neural networks, and also its correlation with different psychiatric disorders. And so, what is mind wandering, and what we mean by mind wandering? Mind wandering happens when one's mind drifts away from the primary task and focuses on either internal task unrelated thoughts or task unrelated images. Mind wandering is a universal experience that represents up to 50% of our daily thinking time. And some forms of mind wandering can be very beneficial for people. For instance, strategic thinking about something important to us. For instance, a grant proposal while we drive a car. But there are other forms which can be very detrimental. Whenever we have spontaneous, uncontrolled thoughts that interfere with tasks such as listening to this lecture or any lecture or any other task we have in hand, that could be detrimental. These two types of mind wandering have been referred to as deliberate and spontaneous, and are thought to reflect a different balance of regulatory processes on internal self-generated thought. Spontaneous mind wandering, which could be detrimental to performance, in contrast to deliberate mind wandering, which is more controlled and regulated mind wandering, has been proposed as a mechanism explaining many of the inattentive symptoms in ADHD, or what we now call it a sluggish cognitive tempo. And this type of mind wandering, this type of spontaneous, detrimental mind wandering could be dysfunctional and represent dysfunctional connectivity between the brain's default mode network and executive control networks. We don't have time to go into details explaining what default mode network is and also what executive control network is. But in general, we all know perhaps that executive functions and executive control networks are the basic mechanisms where we explain uh, how and when the symptoms of ADHD unfold. Um, um, the new understanding of inattentive symptoms implies that on top of executive control networks, we have dysfunctional or disconnection between brain's default mode network and executive control network. Um, in this slide, which is a bit confusing, these uh, basically different neural networks are shown on top of the slide, and the connection between them, topographic presentation of them, and where these different networks are also shown in this slide, which is perhaps not large enough for us to see here. And um, you also see in this graph a correlation between reaction time, variability of reaction time, and ADHD symptoms. And this variability in reaction time um, is explained by how much we daydream, or how much we have excessive, uncontrolled, spontaneous mind wandering. Okay. Okay, so what is a sluggish cognitive tempo? This term, or this diagnosis, has been around for around 10 or something years, 10, 15 years. Now they prefer to call it concentration deficit disorder. They based on DSM, this is part of what we call ADHD, but there are different presentations, there are differences, which I'm going to discuss those differences here. So, what do you mean by sluggish cognitive tempo or concentration disorder? There are several characteristics which makes it different, or makes it distinct from ADHD. The first one is a cognitive dimension of symptoms comprising daydreaming, sleepy, staring, and spaciness. The second characteristic is mental fogginess and confusion. And the third characteristic is motor dimension of slow movement, hypoactivity, lethargy, and passivity. So as I said, it's nowadays called concentration deficit disorder. So whenever we want to call a disorder a cluster of symptoms, a different disorder, a new disorder, we need to establish its validity. And to do a validity study for the diagnosis, we need to do these several things. First, correlation of symptoms. Second, pattern of comorbidity. Third, different or distinct etiology, family history, and treatment response. And now briefly I'm going to overview these different aspects of validity for sluggish cognitive tempo versus ADHD. In terms of uh, impairment and significance of it's being called disorder. When do we call something a disorder? Whenever we have morbidity, like physical injury or mortality, or harm in a major life activity like school, family functioning, relationship, etc. These are the areas where we have or we could have impairment. So uh, we need impairment whenever we want to call a cluster of symptoms a disorder. And both for sluggish cognitive tempo and ADHD, for both we have impairment. Actually, sluggish cognitive tempo is part of ADHD as of now when we use DSM system. And there is a long history of ADHD and also sluggish cognitive tempo, which seems to be somehow different or distinguishable from ADHD. I'm not going into details in terms of history because we don't have enough time. Um, these are, if you want to put together a list of symptoms when we see someone with sluggish cognitive tempo based on frequency of symptoms and also important significance of these symptoms. Here is the list. The first symptom is daydreaming, excessive daydreaming. The second one is trouble staying alert um, or awake in boring situations, in situations where there is not much vitality or variability or vibrations. Um, so trouble. They are easily confused. They are spacey or in a fog. Mind to seems to be elsewhere all the time or most of the time. They stare a lot. They are lethargic, more tired than others. They are underactive or have less energy than others. They are slow moving or sluggish. That's where the term sluggish comes from. They are slow in terms of their movement speed. They don't seem to understand or process information as quickly as others. Um, they are apathetic or withdrawn, less engaged in activities. They get lost in thoughts. They are slow to complete tasks. They need more time than others. They lack initiative to complete work or effort fades quickly. Um, there are some features which could be also hard to be distinguished from um, autistic spectrum disorder. Um, some of the features could be common to both actually, but it's a disorder of itself. Um, okay. So if you want to think about a sluggish cognitive tempo, we should think more or less we have a picture more like um, ADD inattentive symptoms. They are not technically the same, but um, it seems more logical to think that this sluggish cognitive tempo has been a diagnosis most of the time could um, explain what we used to call ADD symptoms. They are usually socially shy. they have social anxiety, they are withdrawn, and this is in contrast to ADHD patients. In ADHD, what we have is externalizing symptoms. We have conduct disorders, uh, comorbidity with disruptive behavior disorder is also very common. And actually, part of the challenges we have as physicians, and also part of the challenges parents have for kids, is the behavioral problems. In contrast, in sluggish cognitive tempo, what we have is internalizing symptoms, anxiety, depression, uh, obsessive compulsive disorder symptoms. There is no issues with impulsivity, no motor disinhibition problems. In fact, actually, they are overly inhibited. Usually, they are withdrawn, shy person, sitting by themselves in a class when they are young in school, and then when they get to adulthood, they have poor social skills. They cannot hang together with other friends or others, which makes it sometimes difficult to distinguish it from ASD. The key here is that in SCT, uh, we have um, the problem is not lack of social skills. They are afraid of interacting with others. The problem is with social anxiety, and this is the key. Also, there is little evidence for executive dysfunction as opposed to ADHD. Or also, there is not much problem with working memory, problem solving, all aspects of executive functions are assumed to be intact. Um, the issue is not with executive function. It's with the information processing speed. Um, that's the issue. That's the underlying issue. This is again the pattern of comorbidity, as I mentioned. There is a very high degree of anxiety symptoms. Also, LD, learning disabilities, is also uh, problem, very common. Okay, I skipped some of these slides. Okay, so this slide shows um, neuropsychology of uh, these different conditions. Sluggish cognitive tempo versus ADHD versus control. So clearly, these are different aspects of executive functions. Um, Clearly, what we see is lack of executive dysfunction in this group as opposed to ADHD patients. Um, in terms of um, frequency and percentage of patients we see in this picture, on average, different studies show that almost one third of patients we used to call ADHD, or we still call ADHD based on current DSM classification, they could be reclassified as sluggish cognitive tempo. Okay, so um, actually, I'm running out of time, and I'm going to wrap it up very shortly. Okay. In terms of etiology, research is very sparse and limited, and no direct studies of neuroimaging or genetics are available at this time. There are some imaging studies, but not clinical imaging in terms of sluggish cognitive tempo. Um, Sluggish cognitive symptoms seem to occur more often in prenatally alcohol-exposed children. Um, Although the sluggish cognitive tempo could be distinguished from ADHD, but there is a significant overlap as well. And also, there is a correlation between family history of internalizing symptoms like depression and OCD and sluggish cognitive tempo. Um, so, in terms of etiology, it's possibly perhaps a dysfunction of arousal and default mode network, as opposed to ADHD, which is an executive dysfunction deficit. It's possibly a disorder of the focus or stability of attention components. We don't know for sure, the, but it seems very likely that sluggish cognitive tempo is a pathological case of mind wandering. Um, okay, I guess I'm gonna stop there for now. I may return to some of these slides later on after we cover um, the other colleagues' presentations, which seems to be very interesting. Um, so the next presentation is on correlation between adult ADHD and adult ASD. This is very important since they are both um, mm, new in terms of how we as psychiatrists diagnose them and the difficulties and challenges of distinguishing any patient with possible ASD from ADHD, and also it seems to be more challenging if you want to diagnose both conditions uh, in the same person. So this is a very interesting topic, and I want to ask Dr. Mahda Motamed um, to present her lecture on ADHD, adult ADHD, and adult ASD. Thank you.
Thank you, Dr. Alagman. Thank you for your presentation. Hi, everybody. As Dr. Alagman said, I'm going to talk about similarities and differences in ADHD, between ADHD and ASD in adults. Let me share with you my slides. Okay. Can you see my slides?
Yes, yes, we can.
Okay. Um, as you know, these disorders are more common in children. It is well known in children, and we all know that these two disorders, ADHD and ASD, start in childhood, but the knowledge and awareness about the adulthood is not that much, and many of patients with this condition may remain underdiagnosed, and sometimes they are misdiagnosed with other disorders. So some needs of them, and usually many needs of them are not well addressed. And so I think understanding the characteristics of these two is very important, and diagnosing these disorders in adulthood is really hard, and it becomes even harder when these two co-occur. And because of this, I think this presentation may be of help. Yeah, I hope so. Let's first start with some definitions and some facts. I don't want to take much time on these definitions, as I think that everybody knows about this. But as you know, ADHD starts or should start before the age of 12 and should persist to the adulthood, and has two different kind of symptoms: inattention and hyperactivity and impulsivity. But the type of symptom and the nature of symptoms sometimes differ in adults, as the tasks are getting more important in adulthood. Some problems in executive function may appear in just adulthood. For example, problems in planning or problems in time management or so on. And ASD is characterized by two different kind of symptoms: problems in social communication and social interaction, and also having some restricted interest or having some repetitive behaviors. Um, about these disorders, the similarities that both are neurodevelopmental disorders, and the prevalence of these disorders are increasing. We don't know exactly why, but an important thing is that awareness and diagnosis of these disorders are increasing. Uh, these two disorders increase and persist to the adulthood to some different extent. It has been said that ADHD persists in about 40% or 60% of persons when they have this condition in their childhood. But about the ASD, we don't have any exact percentage, but we know that almost all of the patients who had ASD in their childhood may have this in their adulthood too. And there is a male predominance in both of the disorders. But it should be noted that um, diagnoses in females in both of these disorders are somehow challenging, and I think, and of course the researchers think that females are more underdiagnosed because of their different pattern of symptoms in comparison to males. For example, girls or women with ADHD usually represent inattentive symptoms, and hyperactivity symptoms are somehow subdominated because of some cultural norms that we have. Um, and in about ASD, girls and women usually learn some superficial masking strategies that uh, maybe make the diagnosis for them a little bit harder. About the prevalence, we know that ADHD has a prevalence of between 3 to 5% in adulthood. About ASD, the prevalence is 100%, but for both of them, we know that the actual diagnosis is much more. And about the co-occurrence of these two, we do not have exact population-based information. The reason for this is that clinicians and researchers were not allowed to put a diagnosis of ASD simultaneously with ADHD before the before the DSMs, before DSM-5. But after DSM-5, it was officially noted, and clinicians were allowed to put the diagnosis simultaneously for one person. And what we know is that these two conditions occur together very much. We know that about 13% of youth with ADHD may have some symptoms and diagnosis of ASD, which is, as you see, 13-fold higher than a normal population. And also, ADHD is the most common comorbidity in children with ASD, which has a rate of 40 to 70%. And this is also, I think, between 8 to 15-fold higher than normal population. But this is not. This is just about diagnosis. But many patients may have some symptom of the other diagnosis that does not complete the full criteria. For example, between 20 to 60% of patients with ADHD have some symptoms of social impairments, which is relatively high. But let's and of course, when these two conditions co-occur, as I said, the diagnosis will be harder. And for example, when a patient had ADHD, this ADHD diagnosis may delay the diagnosis of ASD for example, 2 years, which is really important. But let's take a look at the symptoms and the similarities and differences that may be present in their symptoms and their signs. About the subjective symptoms in normal population, in general population, it has been reported that there is a positive correlation between traits of ASD and ADHD, and people with ADHD have higher scores in AQ, which is a self-report questionnaire for ASD symptom traits, and on the other hand, patients with ASD have higher scores in CARS, which is again a self-questionnaire for ADHD symptoms. Right now, we are doing research on medical students, and we are examining the correlation between ASD traits and ADHD traits in this population. And Dr. Haydari is collaborating with us, and I think he is present here now. Thank you, Dr. Haydari, for joining us here. But what about the symptom overlap? We may see a lot of symptoms in these two groups of patients that maybe look alike. They may look alike, but they are different in their quality. For example, both patients may not deal well with others, but the quality or the reason is different in ADHD and ASD. Patients with ADHD are too impulsive. They want to dominate a conversation, or they want to just do whatever they want. And because of this, they cannot deal well with other people. On the other hand, patients with ASD, they do not have shared interest with others, and they cannot understand others' feeling, and because of this, they do not deal well with others. The same is for having a conversation. Patients with ADHD may talk too much, they want to dominate conversation, they are too impulsive, they cannot wait for their turn. And patients with ASD may talk too much about their own interests, and they don't pay attention to nonverbal clues. They don't pay attention that, for example, their audience are bored or something. Uh, Most of these patients may be hyperactive. Hyperactivity is something very famous and familiar in patients with ADHD, but patients with ASD may have some repetitive behavior that may be similar to hyperactivity, and this should be noted when we are going to put a diagnosis. And both of them have poor awareness of danger. The patients with ADHD may know the risk, but they don't pay attention to that because they are impulsive, and they just see the immediate rewarding. But patients with ASD usually don't understand social clues, and because of this, they may put themselves to so many risks. Um, and if we want to be a little bit clear about these symptoms, uh, we can take a look at inattentiveness. Most of these patients can be inattentive, but patients with ADHD usually have difficulty in maintaining their attention. They cannot have focused attention. But patients with ASD usually cannot switch their attention. They become really focused on their interest, and disengagement from their interest is hard for them, and so they may look disengaged to the other situations, to social situations especially. On the other hand, most of these patients may have may pay a lot of attention to detail. Uh, this is a common. This can be understood by common sense for patients with ASD. They are more focused on details, and when they are in a distress, when they pay attention to some logical patterns or some logical sequences, they get a little bit calmer. What about ADHD? It is a little bit harder to think of, but they may pay attention to details too, because they want to compensate the lack of attention that they have. Maybe you have some friends, or maybe you yourself have ADHD. These are the common strategies that patients with ADHD may use, and maybe your friend or you use. For example, to just don't remember the days, or just don't remember the place of your properties. You may set a lot of reminders for yourself. These are just compensating strategies that patients with ADHD may use. And both of patients have abnormal social reciprocity. Again, this is more clear for patients with ASD. but in patients with ADHD, we have abnormal social reciprocity too. Uh, Both of these patients may be over talkative. Of course, we may think that patients with ASD don't usually talk and they don't want to talk in a social situation, but sometimes they are over talkative and they just want to dominate the conversation and they want to talk about their own interests without any attention or without any caring to other people, and they are not aware of other people, and they may use some, for example, jokes that may seem offensive because they do not know the social rules. On the other hand, patients with ADHD are over talkative because they cannot stop themselves. They lack inhibition, and because of this, they may speak too much, too loud, and they also may become sometimes offensive because um, they do not they lack in some extent the inhibition, and they usually interrupt other people. Social impairment may be present in patients with ADHD too. As you see in this slide, social perception is reported to be lower in patients with ASD, but in patients with ADHD is also lower in comparison with typically developing persons. So social perception difficulties is not just particular or specific to patients with ASD, and it is present in patients with ADHD too. Um, let me pass this slide. Um, Most of these patients have problems in making friends and have problems in their relationships and friendship. But the reason behind this is knowledge deficit in patients with ASD. Uh, and because of this, they are more likely to respond to performance, and because of this, they have problems in their social interaction. We can conclude it to this that patients with ASD have social difficulties due to the absence of positive behaviors, for example, having a good social approach or contact. But patients with ADHD have social difficulties due to the presence of negative behaviors, for example, intruding behaviors or interruption of conversations or being a little bit it is more known about ADHD and executive dysfunction. We know that there are many problems in working memory, inhibition, planning, and problem solving in patients with ADHD. Problems in executive function in ASD is not as much as ADHD, but they have some problems like cognitive problems in cognitive flexibility. Because of this, they stuck on the rituals and they have kind of mental rigidity. Um, And about the intellectual abilities, all in all, they have a lower intellectual ability in comparison to normal population. But when we compare these patients with intellectual disability, we see that the cognitive profiles of these patients are somehow uneven or has a uneven pattern. It means that they are good at some sub categories, but they are not good at some other categories. For example, patients with ADHD, the most problem that they have is on on digit span and problems in distraction. Uh, and in patients with ASD, what we see is that they have a good knowledge, and they usually take or get high scores in information and knowledge in IQ tests. So to discriminate these two conditions, we have to focus on different subdomains of IQ and not just rely to the general score of their IQ. And about the comorbidity, these two conditions have a high rate of comorbidity, but the pattern of comorbidity is somehow different between these two. Schizophrenia and psychotic disorders are higher in patients with ASD, but not in patients with ASD. And the other important difference is about substance use disorders. Patients with ADHD have a higher rate of substance use disorder, which I think Dr. Azadeh will cover this issue in the next presentation. But patients with ASD, as you see here in with these blue arrows, um, have lower rate of substance use disorders. What about the other psychiatric disorders? Most of the conditions have high rate of comorbidities, for example, for anxiety and major depressive disorder and some personality disorders. It is the repetition of what I said, as you see in here in the topest row. Schizophrenia spectrum disorder is higher in patients with ASD, and substance use disorders are higher in patients with ADHD, but the other comorbidities are not that much different between these two. Also, these patients with these two disorders may have some problems in their motor coordination, and also they have some problems in their sleep. But let's go a layer deeper and take a look at the and about the genetic sharing. Of course, there are no specific location for these disorders, but they share some similar locations that have increases in copy number variants with other disorders, ADHD, ASD, intellectual disability, and schizophrenia. And because of this, they may share some common molecular pathways. Um, when we look a little bit in detail, we see that the genetic overlap with trace of ADHD is higher with communication difficulties in ASD, and is moderate for repetitive behavior symptoms. And the relationship between trace of ADHD and social difficulties is not very strong. About the neuroimaging studies, there is a little overlap between the parts of the brain that are involved in ASD and ADHD. We know that patients with ADHD have smaller intracranial volume, and patients with ASD have thicker frontal cortices, but they do not share any specific location. But as a conclusion, we can say that both of the disorders are the disorders of large-scale connectivity. Um, it has been shown that patients with ADHD have some problems in connectivity in precornous area, which is involved in default mode network. But patients with ASD do not have that problem in connectivity in that area. But when we look at this sharing and commonalities, we can say that co-occurrence of ADHD and ASD is somehow better explained and described using dimensional trace. Maybe we should cut across the diagnostic categories and see these disorders as different dimensions and different symptoms, and maybe symptom-specific approaches are more helpful for us to describing these two disorders. And it has been argued that these two disorders are in a same continuum of neurodevelopmental disorder, and ADHD represents a less severe presentation of ASD. And I think that this dimensional approach may make these two disorders more clear for us. Having a dimensional view, we can separate the disorders into their dimensions or their symptoms. And when we look at these disorders with the filter of dimensions, we can see that the genetic overlap between repetitive behavior
Sorry, it shows that Dr. Motamed has been disconnected. We are waiting for her to rejoin again.
Sorry for the interruption. I don't know from when didn't you hear me, but I'll get to you very soon. Okay, I was talking about the dimensions or the symptoms that may help us to distinguish ASD from ADHD. It has been said that when we are interviewing patients with ASD, if we pay attention to impulsivity and if we find any symptoms of impulsivity, we can say that this patient have a comorbid ADHD beside his or her ASD. And about the ASD, when we ADHD, when we are interviewing patients with ADHD, if we see symptoms of lack of empathy, we can say that this patient had ASD comorbid with his or her ADHD. But none of these are clear cut, and for example, we have some data that patients with ADHD also have some problems with empathy. And because of this, many further researches should be done to make it more clear that what are the distinguishing symptoms of ADHD and ASD, or if there are in a shared spectrum or not. But now we have talked about the symptoms and diagnosing and distinguishing. I just want to say some short recommendations with dealing with these patients. Um, Both of these patients should be psychoeducated about their condition, and in our psychoeducation we have to focus on problems in transition. Both of these disorders are neurodevelopmental, and patients have these disorders from their childhood, but now when they are going to step on adulthood, they may face many new problems, and they should be psychoeducated about that. Uh, Both of these disorders have some problems in friendship and their relationships, and have problems with their partners, and because of this, they should be educated about these too. About substance use, they should be educated, especially patients with ADHD. Both of these patients should be educated about sexual relationship and sexual problems that they have. Patients with ADHD usually put themselves to high risk situations, high risk sexual situations. But patients with ASD also may put themselves to higher risk sexual situations because they do not know about this situation, and they sometimes are victimized for sexual abuse and sexual harassment. And both should be educated about pregnancy and parenting if it is applicable for them. Um, Group works may be somewhat challenging for both of these disorders because of intellectual limitations, because they lack concentration, and they usually have difficulties settling down and standing still in the group because they cannot inhibit their urges, and they have a tendency to interrupt the group. And because of this, group work with this population is a little bit hard, but it is not contraindicated. And different kind of interventions should be done for these groups with focus on competence skills, social competence skills, cognitive skills, problem solving skills, assertive training, and so on. But the list may look very nice and great, but these interventions are not always accessible, and because of this, usually in adults, we prescribe medication prior to psychological interventions. About the medication, of course, there are no medication for ASD patients that targets the core symptom of them, but there are, of course, actual medications that are effective for patients with ADHD. But we have to pay attention that we should have a low and slow approach for these population, meaning that starting with low doses and increasing the dose slowly. Thank you so much for listening to this presentation. For the last thing that I want to say is that we should respect this neurodiversity, and we should consider the patient's the wishes and what the patient wants. And we don't want to force patients to change themselves. We just want to help them to be more adapted to the situation. Thank you so much. I think now Dr. Razavi is going to talk about ADHD and substance use disorders.
Okay. What I'm going to be discussing very briefly is the connection between attention deficit hyperactivity disorder and substance use disorder. Actually, I am, in a way, an outsider to this group and the discussions that are made here. But I hope that I will be able to make a connection and a bridge, and to bridge between ADHD and substance use disorder in my presentation. First of all, I should mention that ADHD is a neglected topic in the literature of substance use disorders. As far as I understand, the scholars who are researching ADHD, they know very well that substance use disorder is very common among people who have a diagnosis of ADHD. But on the other side of the bridge, people who are practicing substance use disorder treatment, they much less talk about ADHD among their clients and how it should be managed. This is what I will be covering briefly today. First of all, let us discuss epidemiology. Regarding the epidemiology of substance use disorder in Iran, for example, I should say that it is not so much different from other parts of the world. Some 5% of the population are considered to have a diagnosis of substance use disorder. However, when we include ADHD in our discussion, I should mention that ADHD is as common as 1 in 4 clients who have a diagnosis of substance use disorder. And it is associated with increased prevalence of substance use, abuse, and dependence among those who have this diagnosis. Basically, it is believed that substance use disorder and ADHD comorbidity is prevalent among more than 50% of people who receive any of these diagnoses. In Iran, there are almost few research and publications about the epidemiology of ADHD among people who use substances. A recent study found that among women who have a substance use disorder diagnosis, 35% of them could also receive a diagnosis of ADHD. For male population, the data that we have is somewhat around or higher than 50% of male clients with a diagnosis of substance use disorder. The problem here is that for women, it appears that women who receive a diagnosis of ADHD, they are more attention deficit rather than hyperactivity, rather than having hyperactivity problems. And this is the difference that at least it has been recognized in Iranian clients who have a diagnosis of substance use disorder. ADHD is very high in individuals who are diagnosed as having substance use disorder. Okay, I have already discussed what I'm going to mention. But the point is that when someone has a diagnosis of ADHD, then polysubstance use is much more common among those clients. Therefore, it is not far of imagination to have a conclusion that ADHD should be a predictor of substance use, and the research proves this assumption. The question here is that why do people who have a diagnosis of ADHD begin to use substances? There has been for a long time a theory that perhaps these people are self-medicating, especially those who are using stimulants. There is a controversy about this hypothesis. Personally, I think that this is a correct hypothesis, but some scholars have discussed that this is not a correct hypothesis because why do people who with the diagnosis of ADHD also use other types of substances other than stimulants, say, for example, opioids? But I think that based on this neuropsychopharmacology of different substances, this can be easily explained, and therefore I would like to keep the hypothesis of self-medication. Why this is important? Because if this is a self-medication, then it brings us to a conclusion that as soon as we treat people with the diagnosis of ADHD, therefore then they will not be at the risk of using substances anymore. I will touch upon this topic a little more later. Another reason that is discussed for being at risk of using substances is that these people might have high risk of exposure to substances. And for example, they say that they are unable to control their impulsivity, and when exposed to substances, they start using those substances. Well, is there a genetic association between ADHD and substance use? For a long time, this has been discussed, and nowadays we believe that there is a very strong association, genetic association between substance use and ADHD. In this graph, I'm showing three types of problems. So the first one is those who have alcohol use disorder. The second one is those who have drug use disorder. And the third one shows people with a diagnosis of ADHD. As you see in the first graph, that people who have a diagnosis of alcohol use disorder have a genetic risk score, have a very high genetic risk score for drug use disorder and ADHD. Again, when we are talking about drug use disorder, this longest column, we see that again there is a genetic risk score close to drug use disorder for alcohol use disorder and for ADHD. And when we pay attention to ADHD itself, again, the two disorders that are closest in genetic risk scores to ADHD are alcohol use disorder and drug use disorder. Well, if we change the graphs based on the family genetic risk score and pay attention to the first column in the three graphs, when we are discussing drug use disorder, then we see that, again, the two disorders that are closest to drug use disorder based on genetic risk score are alcohol use disorder and ADHD. Again, when we pay attention to drug use disorder, the two main diagnoses are ADHD and alcohol use disorder. And again, in ADHD, the two closest risk scores are drug use disorder and alcohol use disorder. We are almost sure that there is a genetic correlation between ADHD and substance use disorder. Well, discussing the pattern of substance use disorder in patients who have a diagnosis of ADHD, there are two main patterns. One is that people start using stimulants or alcohol or both together. And there is another type documented to be about clients who use cannabinoids. The problem here is that we do not have such information about Iranian people who are using substances and have a diagnosis of ADHD. Actually, in Iran, we do not pay so much attention for diagnosing clients who are diagnosed as having a substance use disorder, whether they have ADHD or not. I will discuss this again shortly. Well, how are we going to treat patients with a diagnosis of ADHD who are using substances? The first point is that there are reports that early treatment of ADHD will decrease the risk of substance use in the future. Therefore, I think that this is something very crucial that, say, for example, in Iran, if we can have an early diagnosis of ADHD and good treatment of such patients, then this could have a preventive effect on later substance use among this population. If you have a patient with a comorbidity of ADHD and substance use disorder, the treatment would not be as easy as treatment of substance use disorder. We already know that treatment of substance use disorder is extremely difficult. When there is a comorbidity of ADHD, this would become much, much more difficult. There are some reasons for that. We are accustomed that a patient with a diagnosis of substance use disorder does not have a family support. But for treatment of ADHD, we need that family support. Again, already patients who have a substance use disorder diagnosis have very low compliance and low retention rate in treatment programs. When ADHD is added to this diagnosis, compliance falls much, much lower and retention is much worse. Another point is that we already have patients with a diagnosis of substance use disorder that are in critical financial conditions. I would say that the majority of patients in Iran are in this condition. I mean, patients who have a substance use disorder diagnosis. When we come to ADHD, at least in Iran, treatment with methylphenidate would be a real burden for these people. Their critical financial condition does not allow them to be able to have access to methylphenidate. I will discuss this again too. Well, when we are going to treat co-occurrence of ADHD and substance use, first of all, we should be able to distinguish between primary symptoms of ADHD and substance-induced symptoms. This is the problem that I think that we miss many cases of substance use disorders to diagnose them as ADHD too. When we are going to treat them with medications, there are two main different types of pharmacotherapy. First of all is prescription of stimulants, as I mentioned, methylphenidate. Putting aside the financial burden of methylphenidate for these patients, there is a controversy and a discussion going on that whether methylphenidate would result in further dependency to methylphenidate and other types of stimulants or not. Actually, there is no clear-cut evidence whether we should say that prescription of stimulants is safe in this kind of patients or not. But I think, personally, I think that what we have seen in Iran, prescription of methylphenidate would help those kind of patients. And I would recommend it rather than passing on for other types of treatments. Other types of psychopharmacotherapy includes two specific medications, one atomoxetine. My colleagues here in Iran have a good experience with prescription of atomoxetine to patients who have a dual diagnosis of both disorders. Modafinil is a medication that is widely or was widely practiced and prescribed for patients with stimulant use disorder. I do not have any good data from Iranian clients with a dual diagnosis who have received modafinil. But again, I should mention that the substance use literature is also lacking very good evidence about prescription of modafinil. The third type of or second type of interventions are psychosocial interventions. I should say that when treating clients with a substance use disorder, at least in Iran, we are not very good at providing psychosocial interventions that could help them enough for their treatment. When we come to a dual diagnosis of ADHD and substance use disorder, this lack of interventions shows itself much more important, and we see that how we are not doing very well. Well, regarding retention in substance use treatment, as I mentioned, we already see that patients have a very low retention rate. In general, retention rate for substance use disorder is if it is somewhere between 10 to 20%, that would be ideal. But when we see patients with attention deficit hyperactivity disorder, then this retention reduces. What can we do? There are some strategies. First of all, using a more comprehensive psychoeducation programs, using dissonance charts for their treatment, as well as adding cognitive behavioral treatment to the treatment of these patients. I think this is my last slide that is mentioning that if we add pharmacotherapy for ADHD to treatment of our patients who have dual diagnosis, their retention will increase. And if we add some non-ADHD medication, non-medication treatments to these clients who have dual diagnosis, again, retention rates will increase, and we have, if we do not add this treatment, we have a 5-fold increased attrition rate in these clients. Therefore, my conclusion is that for patients who are diagnosed as having substance use disorder, first of all, we should be looking for diagnosis of ADHD. At least 1 in 4 of these clients might have such a diagnosis. Again, if we add to their treatment, a treatment for their ADHD, we will have much higher retention rate and lower attrition rate. Thank you.
Thank you very much, Dr. Razali. Actually, your presentation was very useful, at least to me, and I'm guessing that others have also enjoyed your talk. This is a very important topic. The comorbidity of ADHD and substance abuse has not been discussed enough, and I think for our residents, psychiatry residents, this is an area where we have gaps in terms of training and understanding the importance of this comorbidity. Now we have a few minutes left for any possible questions and we need to come back at 7:30 for Dr. Brown's presentation. Any question? Okay. Um, if there is no question, for now we could take a break and come back at 7:30 sharp. Uh, okay. Bye for now. Dr. Brown, uh, is is Dr. Brown around?
Yeah, I think Dr. Brown is now with us.
Mm, okay, good. Um, okay, welcome, Dr. Brown. Um, we will be with you shortly. Hello, Dr. Brown.
Okay, now can you hear me?
Yes, we hear
Good.
you quite
Okay,
clearly.
very
Okay.
good. It's good to see you.
Okay, very nice seeing you. Look, is everything groovy?
Okay, I hope so. I
Okay.
would like to put on my slides so that we can
Okay.
be sure that they're going to work okay.
Okay. Please do.
So let me do that right now, please.
Okay, I'll let you do your own things, and then we will be back in a few minutes.
Okay, very good.
Hello, Dr. Brown. We are
Hello,
waiting.
can you hear me?
Yes, yes, we can hear you.
Good.
I'm waiting for you to share your screen.
Okay, I'm now trying to do that. It says I am now sharing my screen. Can you see me?
I can see Zoom application in your screen. If you can
Okay,
minimize it.
I was just able to talk with Javad. And
Okay.
Uh, okay, so now we have almost, or to be exact, we have 40 people on board. eagerly looking forward to um, to listening to your talk on ADHD. Dr. Brown is one of the very active scientists and clinicians in the field of ADHD. He has a well-known rating scale which incorporates executive dysfunctions for ADHD patients into a clinical rating scale. We have used these rating scales after checking its validity and reliability in our culture, and that's been a fantastic rating scale. So Dr. Brown is running um, Brown Attention-Related Disorders Clinic in California, and he's agreed to discuss ADHD uh, today with us, and I'm very grateful to his accepting my invitation. Dr. Brown, please.
Thank you very much, and I'm very grateful and feel honored to have this invitation. So I will now proceed to share with you some things about the work that I've been doing, and I hope it will help you in your work. First, I'd like to address the question of what is the main problem in ADHD. And I should say that sometimes I use the term ADHD, sometimes I just say ADD, but I mean the same thing. This disorder, what we now call ADHD, has been around for a long time. It was first written up in the English medical literature in 1902. But from 1902 until 1980, it was simply about little boys who couldn't sit still, wouldn't shut up, and were driving everybody nuts. What's been happening, actually, it was not until 1980 that the term attention deficit was included in the name of the disorder. But now I think that the research is clearly moving toward an understanding of ADHD, which says that ADHD is a developmental impairment of the brain's self-management system, or to put it more specifically, its executive functions. And that in the case of ADHD, for these people, some aspects of the brain's executive function simply do not come online in the usual time frame for persons of the particular age we're looking at. And often they do not work consistently. And that's what I'm going to try to talk about today. Now, I think that we could probably define this as executive functions, meaning a wide range of central control processes of the brain that connect and then prioritize and integrate our cognitive functions for us moment by moment. And the metaphor that I often use to think about this is, if you picture a symphony orchestra where all the musicians are very good at playing their instruments, regardless of how good they are, if you do not have a conductor who can select what they're going to play and who can keep them on time and bring in the strings and then fade out the strings, pull in the timpani and bring in the brass and organize them and start them and stop them, without a good conductor of the symphony, you do not get very good music from the orchestra. And these executive functions that I'm talking about are operating as the neural circuitry of the brain that serves as the conductor of the brain's symphony. one of the terms that you'll often hear from people talking about ADHD is focus. But I'd like to emphasize that the focus that we're talking about here in ADD, it does not mean hold the camera still so I can take a picture. And it does not mean being able to focus just on one particular thing. It's more like what we mean when we say focus on your driving. Because if you think about what happens when we focus on our driving, we are not gluing our eyes to the bumper of the car in front of us. We're watching what they're doing, but we're also noticing there's a truck backing out of the driveway and we have to look out, and somebody has foolishly opened a door wide into the lane of traffic we're trying to drive in, and so you don't want to hit them and take their door off and their leg. And at the same time, you're looking down the street and there is a stoplight, which has been green and now it's turning red, and you have to get your foot off the accelerator and over to the brake. And meanwhile, you may be needing to get over to the next lane to get ready to make a turn at the next corner. And while you're doing all this, you're remembering what you just saw, you're ignoring some other things that you can't afford to be looking at more now. And you may also at the same time be thinking to yourself, what do you want to buy when you get to the grocery store? So it's a kind of focus of pulling the pieces together in order to be able to get things done. That's what executive function focus is really about. Now, before I go further, I would like to emphasize two things that I think are very important for understanding ADHD and its symptoms. The first is this is a dimensional problem. It's not an all or nothing thing. You know, this is not like pregnancy where you are or are not pregnant and there's nothing in between. It's more a problem of you know, like depression, where everybody feels sad once in a while, but just because someone is unhappy for a day or two does not necessarily mean that we would diagnose them as clinically depressed. It's only when those depressive symptoms are persistent and making a lot of trouble for somebody, we would say, yes, that's a depression, we should do something about it. Now, the other bullet on this slide is speaking of situational variability. And I'm going to talk more about that in just a few minutes. But right now, let me preview by saying that I have seen thousands of children, teenagers, and adults who have ADHD. And every single one of them has a few tasks or activities where they have no difficulty in exercising these executive functions, which are very problematic for them in almost everything else. More about that in just a few minutes. First, this is a model. This diagram is showing you a model of the elements that I think of as important components of executive function. If you look along the bottom, you will see these terms: activation, focus, effort, emotion, memory, and action. But I would like to emphasize that these are not unitary variables where it's all one thing. Rather, you might think about these as labels on a basket of related cognitive functions. That, for example, with activation, I'm referring to the brain's ability to help us organize and prioritize what we're going to do and then to get started on it. And similarly, each of these boxes is talking about aspects of cognitive function, but it's not a unitary variable. It's more like a basket of related cognitive functions. A second thing that I would emphasize here is that all of these functions are developmentally progressing, which is simply to say that with a very young child, their ability to manage things for themselves is, of course, quite limited. But through early childhood, gradually we begin to develop the capacity to do some of these things which earlier in life had to be done by grown-ups or other people around the family. So this is a developmental process, these functions, these executive functions. It's not one fixed entity. But the other thing that's important to say about it too is that these functions operate mostly unconsciously, which is to say that that they do not have to be thought about very much as we do it. So I'm talking about this as unconscious, not in the psychoanalytic sense of repression, but rather in the more modern sense of automaticity, that they operate so quickly, so automatically, that much of the time we don't need to think about them at all unless we're faced with a new task where we've got to slow down and operate in a more conscious way. But if you think about it, for example, an athlete who is playing basketball does not, as he's playing, say, okay, now I move my left foot forward, now I move my right foot forward, now I lean over to the other side, now I step up on my toes. These are all motions that one goes through so quickly and without much specific thought about it, except when we're dealing with a novel situation or one which is puzzling to us. So these these 6 different categories are intended here to refer to the totality of executive functions, which operate for the most part unconsciously. I'm going to go through these now one by one just to give a little more detail about what I have in mind. Under organizing and prioritizing and activating, there are these several elements. One is being able to get organized. Now, it's tasks and materials. Think about it in terms of how a child learns gradually to put into his or her backpack the materials they need to take to school, and then on their way home to repack them so they'll have the materials needed to do their homework. But that also involves being able to prioritize and think of what needs to be done first, what needs to be done next, and next, and next. Many times when you talk with people who have ADHD, they will say to you, when I have a bunch of things to do, they all seem equally important. And it's very difficult for me to look at and say, okay, that should be first, that should be second, and that should be third. People with ADD also report that they have more difficulty than most others of similar age in prioritizing tasks and in estimating how long something is going to take. But probably the most problematic part of this is the third bullet. And that is that people with ADHD often say that they have a lot of difficulty getting started on tasks they need to do. That they tend to put it off. It's like, yes, I know today I should be, working on that paper I need for school, but I think probably I'll do that maybe later today or perhaps tomorrow. And then often things get put off until one has to rush to finish it and not be able to do the job as well. The procrastination is a very common complaint among people with ADHD. So this is just one of the 6 clusters: organizing, prioritizing, and getting started. And please keep in mind that we are always needing to keep a developmental perspective. That what it means to get organized if you're a 5 or 6 year old kid is very different from what it means if you're an adult who's running a family and has to take care of children and also a job. This is the second cluster here. Focus, I spoke about that a moment ago, but let me just elaborate on a couple of other things that often people find who have ADHD will complain that they have difficulty in being able to stay focused when they're trying to listen to conversation or to lectures like this, or when they're trying to plan a task that very often they get distracted, sometimes by other things going on around them, noises or activity that distract them. And sometimes they just are distracted only by their own thoughts. But they find it difficult that they will start working on one thing and then pretty soon they're thinking about something else and lose track of what they had intended to do. And sometimes the distractions are external, other things going on around them, and other times they are internal, thinking about various other concerns that may have very little to do with what's going on. But I would like to mention in regard to the third bullet, something that I think is very important when we're evaluating students and also other adults. And that is that many people with ADD complain that when they read something, they understand the words as they read them, but often they find that when they finish reading, they'll read a paragraph or two on a page, and then they turn the page to read further and realize their eyes have gone over every word. They understood it all as they were reading it, and now they haven't got the foggiest idea of what they just read. And it's very frustrating for them because then often what they have to do is go back and read the same passage again. And this is an example of something we'll be talking about when we get to a little further along with this model. But the issue here is that it's a matter of being able to focus, but also being able to utilize short-term working memory to keep in mind what you just read on page 1 when you're starting to read now on page 2. The third cluster in this model refers to regulating alertness, sustaining effort, and operating with appropriate processing speed. Now, one thing which is often not spoken about with regard to ADHD is that people with ADHD often struggle to manage their sleep and alertness. That many times people with this disorder will say, I often stay up a lot later than I want to or should, because I find if I try to lie down and go to sleep, and I'm not really tired, I'm just not able to let myself go and fall asleep. And so they'll stay up late and then find that they have not enough hours to sleep and often feel very tired and have a struggle. It feels like trying to wake the dead in the morning. During the day, they're usually okay if they're on their feet moving around. But if they have to sit still for a long time to listen or to read or to do paperwork, often their eyelids begin to get rather heavy. They get drowsy. The other bullet here has to do with being able to sustain interest and effort. And that is to say that many times people with ADHD will tell you that they can be excited about doing something, but then after they get started at it, sometimes the interest diminishes and it's hard for them to stick with what they need to do and to complete it. And as a result of that, often it's difficult for them, if they are students, for example, or business people, to finish a task in the time frame, especially if it involves writing. that I had a patient one time who was saying, you know, it's as though my mind is a very good computer, which can think of many different things, but I have a very slow modem. It's not possible for me to process this information very quickly. I have good ideas about what I want to write, but then I have a lot of difficulty in being able to put those ideas into sentences and paragraphs, which I and others can read. The fourth cluster of this model, which I'm working with here, is talking about something which is not included in the diagnostic manual or the ICD-11, neither the DSM-5 nor the ICD. And that is that one aspect of ADHD, I feel, is managing emotion, being able to modulate emotion and manage frustration. Let me give you a few examples. People with ADHD, well, I remember, for example, one man who was a salesman, he said, I was at the diner at the restaurant eating lunch yesterday, and I was in a good mood sitting there eating my sandwich, and then a person sat in the booth behind me, and he was just chewing very loudly, chomp, chomp, chomp. And there was something about that noise that was driving me nuts. It's as though it's a computer virus that's just gobbled up all the space in my head, and that's all I could think about. And I was sitting there with my fist clenched, seriously thinking about hitting him in the mouth because he was being so rude. But then after a few minutes, he said, then it didn't even bother me anymore. Often people with ADD will describe that they have hair trigger, very quick emotional responses. Actually, the same man said, you know, the day before that, I was working at the office and I was walking down the hall, and I saw my friend who works in another department coming around the corner, and he was reading some papers as he was walking. I hadn't seen him for a long time, so I stopped and said, hey, what's up? How you doing? I figure we'd chat for a minute. He looks up, says hi, puts his head down, keeps right on walking. He said, now most people would blow that off in just a minute and think, well, he's in a hurry, he's got to get to a meeting or something like that. But that's not how it was for me, he said. I kept thinking about that all day, and I was wondering, is there something I did that made him angry? Or maybe he just doesn't like me, or maybe I'm just somebody that a lot of people don't like. I couldn't get it out of my head. It's like the computer virus invading the hard drive. I have a hard time putting it to the back of my mind, but it's not always that kind of difficulty. Another thing that you hear often for people with ADD, and particularly parents complaining about their children, is that they have this intense sense of, I have to have it now. They think of something they want to get, or something they want to buy, or something they want to do. And all of a sudden, that one thing becomes so important they can't think of anything else. And so they'll keep thinking about it and thinking about it. It's very difficult for them to put it to the back of their mind. And meanwhile, they're thinking, you know, they don't even realize how they're going to pay for it, or whether they're going to use time and money now for something, this thing, when they need it for something else. And then one final example is that people with ADHD often have difficulty with worry. I'm thinking about a woman I saw, and she said, you know, I was driving on the freeway, on the expressway the other day, and I was in this left lane, and then right a little bit ahead of me, in the next lane over to my right, was a very large truck. And as I'm driving along beside this truck, I'm thinking to myself, what happens if he didn't see me? And if he pulls over and squishes my car against the side of the barrier on the road? And I started imagining immediately what it would look like if that happened, about, you know, sharp metal pieces hitting me and I'm bleeding. and the car is getting squished, and I'm bleeding to death, and traffic is piling up, and it takes a long time to get the rescue squad in to cut me out of the car, and and I'm dead. And I'm not able to just put that to the back of my mind. So I'm using these examples to say that people with ADD often find that when they're frustrated, when they're worried, when they're feeling intense wish to get something or to do something, often those emotions gobble up all the space in their head, in their consciousness. And it makes it very difficult for them to manage. Now, this is not something which is included in the diagnostic criteria for ADHD, but when you're working with patients who have ADHD, whether children or adults, you're likely to find that managing emotion is a very important part of what they struggle with. Now, the fifth and one very important part of ADHD is working memory. If you ask people who have ADD, how's your memory? Often they'll say, oh, I've got the best memory in my family. I can remember stuff nobody else can remember. And they give an example of some movie they saw 10 years ago. They've seen it only once, and they tell you every detail, the entire story of that storyline of that movie. Somebody else might say, oh, I went to see this very good football game, and I can tell you almost every detail of everything that they did, all the moves in that game. Or somebody else will say, I have in my head 450 songs that were popular back in the 70s, all the music, all the lyrics. But though people with ADD are often pretty good at remembering things from a long time ago, they often have difficulty in keeping in mind what's going on right now and in the past few minutes. For example, they will say when they walk out of their house in the morning, I need to remember to stop at the grocery store and get some milk and a couple of other things before I come home because I need those for preparing dinner. And they often will find that they just completely forget about being able to remember those things. Or they'll be thinking about trying to think about something that somebody just said. For example, this is something I think all of us have from time to time. You know, you go in the other room to get something and you're standing there scratching your head trying to remember what in the world it was you came into the room to get. Or you have to call a telephone information operator to get a telephone number, and you have to hold it in your mind before you dial it because you don't have anything to write it down with. Often people with ADD said that they then jumble those numbers. Other people students will say they'll study for a test the night before the test. Someone asks them the questions and helps them to study. And they go into the school getting ready to take the test thinking they're going to do well. And suddenly a big chunk of what they knew the night before has evaporated. Can't pull it out of their head when they need it. But then a few hours or a couple of days later, it's all back again. It's not that they didn't have it. It's they couldn't retrieve it when they needed to. Working memory, short-term working memory is a very important part of ADHD. Now, the sixth and final cluster of symptoms in the model that I'm describing for ADHD has to do with monitoring and self-regulating action. Now, you know, for years, everybody has thought about ADHD in terms of hyperactivity, restlessness, and very impulsive behavior. And it seems as though often, particularly children, in comparison with other kids of the same age, have difficulty in being able to settle down, and that often they're moving around all the time or keep talking long past the point where they should have been quiet. And it is just, you know, notably restless. And as a result, often they're not sizing up situations very well. I was talking with a man recently who said, you know, I love target shooting, but I'm terrible at it. And I said, why is that? And he said, well, you know, when I go to the range to practice, you have to get your rifle up and line up your sights so you can see where on the target it is that you're trying to go. And he said, they teach you ready, aim, fire. And I know that, and I recite it to myself when I go to practice my shooting. But the fact is that with me, I get my finger there on the trigger and I'm looking carefully to try to line up the sights on my rifle, but I don't do ready, aim, fire. I do ready, fire, aim. It's like I cannot stop long enough to really line up my sights and be able to adequately, hit the target. But he said, I like it anyhow. So these are just examples of impulsive behavior and of restless and somewhat hyperactive behavior. But I also want to mention that the people with ADD are not always hyper. In fact, there are many people with ADD who tend to be rather sluggish, who are slowed down. They speak slowly, they move slowly, they have a hard time getting started on doing things. All people with ADD are not alike. So what I'm proposing here is that, that ADHD might be thought of. You could write an equation that says ADHD is essentially a developmental impairment of the brain's self-management system, its executive functions, of its neural networks for deploying and managing various skills. This is this. I'm just reminding you again of the metaphor of these executive functions being like the conductor of an orchestra. Now, remember I used these words before, and now I'd like to come back to it, and that is the issue of the situational variability of these symptoms. And what I mean by that is that all the patients I have ever seen, and there are quite a few of them of various ages, who have ADHD, also have a few activities where their typical ADHD symptoms are not present. That they are able to execute whatever they're trying to do without the difficulties that I've just described. Let me give you an example. A 16-year-old boy was brought to my office by his parents, and he was the goalkeeper for his school's ice hockey team. And it just happened that the team had won the state championship in ice hockey the day before. The parents were proud and spoke about how well he did, how well he performed. And apparently he was also a very smart kid, tested way high up in the superior range, wanted to get good grades, was hoping to go to medical school, but he was always in trouble with his teachers. And what they would say to him is, you know, once in a while, you'll say something that shows how smart you are. We'll be talking about something, you'll come in with some comment that's really very perceptive and it's impressive. But most of the time you're out to lunch, you're looking out the window, you're staring at the ceiling, you look like you're half asleep. It's very difficult to get your attention. And they were puzzled. If you could pay attention so well when you're playing hockey, this is their question to him, why is it you can't pay attention when you're in class? And I think that's an important question because most people with ADHD get hit with this question a lot because they may be very good at focusing on one thing like playing a sport or like playing video games or making art or engaging in some other activity which is especially interesting to them, or where they feel like if they do not get this particular activity done, then something that they do not want to see happen is going to happen. You know, the situational variability of ADHD means that the symptoms are not constantly present. Typically, they are not present in activities where the person is doing something in which they have strong personal interest, or where they feel that it's likely that if they don't take care of this right here, right now, something they do not want to see happen is going to happen. So this is going back now to, remember, this is true of all of these different executive functions that we talked about. So the question is, why is it that a person can focus for this but not for that? And usually what they'll say, people will say is, if it's something that really interests me, I can focus. Or if I feel that it's like a gun to my head, that I'm afraid that something I don't want to see happen is going to happen. And the question then is, why is the motivation in ADHD, and it is a disorder which involves problems of motivation, so variable from one situation to another? And this has to do with the link between perception and emotion. One way of thinking about this, I had a patient one time who said, I have a sexual example for you for what it's like to have ADD. And he said, having ADD is not a matter of willpower. It looks like it's a problem with willpower. You can do it here, why can't you do it there? But in fact, it's a problem with the dynamics of the chemistry of the brain. And he said, what I thought about as an example is, it's like having erectile dysfunction of the mind. If the task you're trying to do is something that turns you on, you're up for it and you can perform. But if the task you're faced with is not something that is particularly interesting to you or particularly scary to you, in that you don't want to see it happen, then you can't get it up. And if you can't get it up, you're not going to be able to perform. ADHD often looks like it's a problem of willpower when it's not. It's a problem with the dynamics of the chemistry of the brain. It's essentially a chemical problem, which has implications for how we treat it. The most effective treatment for ADHD is to change the chemistry of the brain with medication. And unless that problematic chemistry is changed, many other interventions which one might want to offer are not going to be very effective. Now, what do we know about the medications? In the United States, there are basically two categories, and in many other parts of the world, there are basically two categories of stimulant that are effective for treatment of ADHD, and there's a substantial body of research on this. One is methylphenidate. An example in the US that's referred to a brand is Ritalin. Or the other are amphetamines. And I assume that you know your chemistry enough to know that the difference between these two is that both of these medicines the mechanism of action is they slow the reuptake process after the message has been crossed. I'm going to show you a picture in a moment, but let me just say a couple of general points and then we'll look at a diagram, which I think will help to clarify it. These medicines that we have approved for ADHD, methylphenidate and amphetamine, have been demonstrated safe and effective by a fairly large body of work. But one thing which is often not recognized by prescribers is these medicines do not follow mg per kg, in terms of deciding of what the dose should be. The effective dose is not based solely on age of the person or their weight or the severity of their symptoms. It has to do with how sensitive their body chemistry is for these particular medications. And so this requires careful titration and monitoring to fine tune according to the individual sensitivity of the person's body chemistry and the time frames of when they are doing various tasks. You're looking for the sweet spot between too little and too much. If you have too little, it doesn't do a damn thing. If you have too much, then one of three things happens. You feel kind of jittery, like you've had way too many cups of coffee, or you get irritable, or you get a blunting of emotions where a person does not feel very interested in talking with other people. In this illustration, you will recognize it as we're looking at a synapse, and what we're seeing on the upper end of it, in terms of this mechanism of action for stimulant medications, is that you get the action potential coming down the neuron. Remember, these things are about 2/3 the diameter of one human hair, and we're looking at just two neurons, specifically two lonely little neurons talking to each other. But the fact is, these travel in cascades, as you know. And so we have the vesicles near the sending side of the top neuron. And then they release, when the action potential comes zipping along, the release dopamine as a result of amphetamine, or the chemistry of what's set up here. And then these little stars are supposed to represent the molecules of the chemical that's hitting the receptors on the postsynaptic side. And the mechanism of action, and I should say that these red torpedo-shaped objects on the sending side are supposed to represent the reuptake, the process of uptake, the transporters. Okay, so you get the release of the action of the dopamine with the action potential coming in, hits the receptors, and then you've got the reuptake process sucking the chemical back into the sending side. Now, that's true for both methylphenidate and amphetamine. However, there is one more thing which happens with amphetamine, if you have that available to you, and that is it packs a little more punch because it also releases a little bit more dopamine in the first place. That's the critical difference between methylphenidate and amphetamine. Both are useful for treating patients with ADHD. However, for some, one works and the other one doesn't, or you get side effects with one and not with another. But people do not come with labels on their forehead to tell you which category they belong to. Now, I'd like to take just a moment here to talk about the process of what I'm calling rebound. And that is to say that if you look at this diagram, this is the ingestion of the medication. And for the short-acting medicines, usually it kicks in about a half an hour. For the longer-acting, it will usually take closer to an hour or more. And then there's the duration of action, which can vary anywhere from 3 or 4 hours for short-acting, or 8 to 10 for long-acting, and then it wears off. Now, if during this time when it's supposed to be working, the person is feeling wired, like they've had way too many cups of coffee and they're kind of jittery, and then that gets better when the medicine wears off, the dose is too high, or it's not a good medicine for them. Or if they get very irritable and crabby during the time the medicine's active, and then that passes as the medicine wears off, dose is probably too high or not a good medicine for them. Or if you get too serious, a kind of blunting of emotions, and they don't feel much like talking to anybody, again, likely the dose is too high or just not the right medicine for them. However, if you are not hearing these complaints from your patients about the time when the medicine is active, but they do complain that it's happening later in the day when you'd expect the medicine to wear off, that's a completely different problem. That's what we call a rebound. And what it means is not that the dose is too high, that you would have seen here. What it means is it's dropping too fast and the person's crashing. And it's usually quite easy to fix that problem if you give a small dose of the short-acting version of the same medicine, so you can build a more gradual exit ramp. And this is what we call a rebound problem. Now, it's important, and you think about this, not only to be prescribing, but also to fine tune the medicine, but also to set the expectations of the patient. Let them know you need their collaboration. You want to know if they're having difficulty with the medicine. You need to know about when in the day, when in the course of the time of the medicine. You want to be able to hear about, are they having troubles later in the day, and encourage them to report side effects so you can use that information to effectively fine-tune what you're doing. Meanwhile, I'd like to take just a moment to talk about comorbidity, because the reality is that whether you're talking about children or teenagers or adults, in addition to ADHD, they're very likely, the patient is very likely to have some additional problems. And this is a report of a study by Dr. Amerikangas years ago, where she was studying over 10,000 adolescents, 13 to 18 years old. And 14% of those kids had a mood disorder. 31% and had an anxiety disorder. Another behavioral disorder like oppositional defiant, about 20%. Substance use disorder, about 11%. Eating disorders. And then if you look at the bottom here, about 58% of these students that were involved in the study had at least one other disorder of one of these classes. And then for those in the group who had, there were 24% who had two different types of medicine, and there were 18% who had three, which is simply to say, when you're looking at ADHD, about half your patients are going to have at least one other learning or psychiatric disorder comorbid with their ADHD. Now, I'd like to just mention briefly, I've been working with the special interest, just came out with a new book about ADHD and autism spectrum. We've got pretty good data that says between 12 and 18% of those who have ADD also have some autism traits. And at between 30 and 85%, the wide margin is because there are different measures used, of those diagnosed with autism spectrum disorder have ADHD. I think the number is closer to 85 than it is to 30. And what that means is it causes significant social impairment. They tend to lack empathy. Their nonverbal communication is often not very good. And they have difficulty developing friendships with peers. And their pragmatic language, just being able to make conversations, is problematic. And often they are stuck on an absorbing interest in one or two specific things that blocks them from being interested in much of anything else that's going on. But yet I think it's important to say that there is a spectrum of symptom severity and also of cognitive abilities. And my more recent research has been focused on those that used to be called Asperger's before that term was removed from the diagnostic manual, which I think was a mistake. The ones who have average or above average intelligence will also have Asperger's or autistic features. These patients certainly need some school support, but if they have ADHD, they also need some medication treatment for that and some help with understanding social skills that most other kids pick up intuitively. Stimulants can be quite helpful for them, but it's important with these patients especially to titrate cautiously. They tend to have very sensitive body chemistries, and if you come in with the usual starting dose, you may very well find that they don't respond well to it. I'm talking now about methylphenidate and amphetamine. These are the two medicines that we use most often for treating ADHD. And I'm also referring here to atomoxetine, Strattera, which is also been demonstrated to be helpful, although I think stimulants tend to do the job better. And then for those who also have OCD or excessive anxiety, sometimes you supplement the medication for ADHD with an SSRI in order to try and alleviate some of the OCD symptoms or reduce the anxiety. I think I'm going to have to bypass the two case examples I was going to use because I've been talking too slowly and I want to leave time for questions. And let me just say that I'd like to emphasize the importance of professionals knowing about Asperger's syndrome, both clinicians and also teachers, and to provide adequate scaffolding and personal support for them and use the teachable moments to be able to help them understand social interactions as well as fine-tuned medications for ADHD. Joe Biederman at Harvard, in one of the papers that they've done on this issue of ADHD in people with Asperger's syndrome, said, failure to recognize ADHD, especially in the intellectually capable kids with autism spectrum disorder, can seriously undermine their educational and social functioning, worsening already compromised social performance, and can predispose these kids to increased risk for disruptive behaviors, mood dysregulation, and substance use disorder. Treatment is, first of all, education about the disorder, the patient, the family members, and the educators. Provide adequate scaffolding and personal support, and then fine-tune medication. So let me just summarize the main points I've tried to make. One is that I'm thinking about ADHD as developmental impairment of the brain's executive function. It looks like a willpower problem because you can do it here, why can't you do it there, when in fact it's not. It's an inherited problem in brain chemistry. Out of every 4 people diagnosed with ADD, one of them has a mother or father who's got it, whether they know it or not. And the other 3, if they don't have a parent, usually there's a grandparent, an uncle, an aunt, or a cousin or brother or sister. It's highly heritable. 0.76 on the 0 to 1 scale of heritability. Medication treatments for ADHD often help people to deploy or be more available to learn skills they need. Often ADHD is accompanied by 1 or more additional disorders like anxiety, depression, Asperger's syndrome, which require some adaptation in treatment. And that untreated ADHD tends to make autism or other disorders far more problematic. What you see on this slide is that these are books I have published on this topic, and the one that each of them talks about ADHD. The most recent one that really gives comprehensive descriptions about medicines and the developmental differences is this book called Outside the Box: Rethinking ADD, ADHD in Children and Adults. And another book of mine that's more recent that's Smart But Stuck. It talks about the role of emotions in teens and adults with ADHD. It's got a dozen case examples in it. And then this is my newest book, which just came out this past week on ADHD and Asperger's syndrome in smart kids and adults, 12 stories of struggle, support, and treatment. So these are resources that you might want to look for. And this is my website, www.brownadhdclinic.com. And there, if you go to the resources section of the website, you'll find there are a number of papers and articles that you can download for free. So let me, at this point, stop, and I'll be happy to respond to any questions that you would like to put.
Thank you very much, Dr. Brown. I really enjoyed your talk, and I'm sure everyone else has found it useful and quite educational. I have one question for you, if you wouldn't mind.
Of course.
Have you found coaching useful for executive dysfunctions?
I think that the coaching, if you've got a well-trained coach, now I don't know about how it is in Iran, but I can tell you that in the US, we're just in the process of developing certification programs for people who do coaching for ADHD.
Mhm.
And some of them are very competent people who are very helpful to patients, and others are very enthusiastic but less competent. So it's important to not only have a coach, but also to find somebody who's been adequately trained. But
Yeah.
I also would add that and would emphasize that because of the centrality of the chemical problems that underlie ADHD, the most effective treatment of any for ADHD is appropriate medication if that's available.
Yeah, actually, we are also in the very first steps in terms of um, establishing some ground rules for coaching,
Mm-hmm.
and we are actually we are quite worried how we could, monitor
Yeah.
what other people do and so
Well,
forth. But
I think coaches need to be uh, aware of the importance of not only their knowing about ADHD themselves. Many of them have the experience of having ADHD, but also to be encouraging the people they're working with to maintain close contact with their clinician so that the
mhm,
medication treatments can be made effective.
yeah, okay. But under proper circumstances, you find it helpful, right?
Yes, it's often very helpful because the fact is most of us clinicians have a lot of patients to take care of and do not have enough time to be constantly consulting with people. And if you've got someone who understands ADHD, and particularly if
Hmm.
they've been through it themselves, and they're available to talk with the person on a regular basis, perhaps on the phone, and perhaps on a daily basis when the person is first getting started with treatment, that's a very valuable resource.
Okay, okay, thank you. There are a few questions in the chatting section. If you have access to it, I can read it to you if you don't know where it is.
Okay, I am reading this. It says, thank you so much. I have a question. Sensory integration is useful for this problem. Actually, particularly for the patients who on the autism spectrum, because their sensitivity to various kinds of sensory input, whether it's auditory or touch, or smells, is much stronger. They're much more highly sensitive than most other people would be. And that is important to take into account as part of the treatment picture.
Okay. There are two other questions on top. Do you see them as well?
I get the questions only as they're being, well, let's, I don't see another question right now.
Okay.
Can you, if you could read it to me, I'd appreciate it.
Oh yeah, sure. Sometimes ADHD diagnosed late. For example, maybe at age 50, is the medicine effective for them?
Yes, actually, my youngest patient right now is 4 years old, and my oldest patient is 76.
Mhm.
My special interest is in high IQ patients, and the
Okay.
reason that I have been especially interested in them is that they often are overlooked. That people will see that someone who's very bright can do very well in a few things that they're really interested in. And it seems as though they're just being lazy when they do not show the same energy and the same effort uh, in dealing with other matters that are not so interesting to them. For example, their school courses, or at least the courses they do not like very much. And
Okay.
so what happens is that often the smart, or really smart kids who have ADHD often do not get picked up in the
Mhm.
early years of school, and until the work begins a little to be more difficult for them, and then they have difficulty in being able to keep up, and then people get angry with them because it looks like they're just not trying hard enough. Um, and it's important for clinicians and teachers to be aware that sometimes the brighter kids uh, who have ADHD do not show up as having ADHD until they encounter the challenges of the higher years of schooling.
Okay. I guess the question was uh, uh, for this question, they wanted to know if um, old age is a limiting factor. Excuse me. in terms of treatment or
No,
med?
we basically do treatment with patients who suffer from the symptoms of the disorder. And you always want to take a careful look at what the possible co-occurring or comorbid disorders might be. Because
Okay.
as I suggested, that there is a very high incidence. For example, if you look at adults at age 40, people with ADHD have 6 times the likelihood of having a comorbid disorder compared to people who don't have it.
Mhm.
Uh,
Okay.
so it's a comorbid. Actually, comorbid is what I was trying to say.
Okay. Um, the other question has to do with gene therapy. And if there's anything you know about gene therapy for ADHD.
There's not much work at this time that I'm aware of for gene therapy. It's interesting stuff, but the fact is, the we don't know. We do know that the genetics are very important in ADHD, and if you think about the heritability index, which runs from 0 to 1, breast cancer is about a 0.3 on that scale, asthma is about 0.5, height is about 0.9, and ADHD is about 0.76. It's
Mm-hmm.
highly heritable. And
Yeah.
so we know that. But it's also important to know that it doesn't always appear in the same you know, symptom presentation with members of the same family. For example, you may have uh, 2 parents who have 3 kids, and one of
Mm-hmm.
them may have ADHD with the hyperactivity. Another one may have a kid with ADHD, but no hyperactivity at all, just inattentive symptoms. And then the third kid may have no ADHD at all. So it doesn't always go by subtype in the genetic presentation, uh, but you can see it either way.
Okay. Um, the other question for you, would you please explain about your scale and how it helps us to find problem in executive functions?
Okay, the rating scale, which I believe you have translated now,
Yeah. Yeah.
um, is a tool which I developed to ask a series of questions of patients um, about their experience in the 6 different clusters of symptoms that I presented in this conversation in my talk today. Uh, and it gets much more specific. And then there are norms for it so that you can see how their presentation is different, uh, from what you'd expect to see of someone else of comparable age.
Mhm. Okay. Thank you. Thank you. Um, are you still ready for the questions? Are you?
Okay, I see one that's on my screen right now. It says, assuming a patient with AD is, okay, I just lost is having
Assuming it,
difficulty.
okay.
Uh, oh, I see the question of, is it different in terms of how long do you stay on the medicine? I think about the medicine for ADHD not as something which is curative, uh, but it's more like eyeglasses. I have a problem with my eyes. I can't read typewriter size print without my glasses. When I put my glasses on, I can read that print as well as anybody else. But if I take them off, I'm right back where I started. The glasses do not fix my eyes. They just help me see when I've got them on. And in the same way, the medications for ADHD do not cure ADHD. What they do is simply to improve the symptoms to allow the person to be able to focus and exercise these executive functions better. And then when the medicine wears off, you're right back to where you started.
Okay. Okay. Um, do you want me to read it, the other ones to
Yeah,
you?
I can take a few more.
Okay. Whenever you get tired, just let me know. Okay.
Okay.
Okay, so what's the impact of a patient with, treating an educated patient versus non-educated or layperson in terms of, I assume in terms of, yeah, executive function and so forth.
Yeah, well, I think that the expectations that you have for someone who is very bright, they're more likely to be going on to more advanced education, and they are likely to struggle with their ADHD, except in those areas where they have strong personal interest. And sometimes you don't see the problem when they're in the earlier years of their schooling because they're smart enough that they can pick up a lot of things more quickly than their peers. But when they start getting into more advanced classes and the challenges that go with that, um, you can begin to see the difficulty. So we have patients who come in for the first time when they're in university, and we have patients who come in with their kids when the kid is a teenager and the parent is in their mid 40s or 50s, and they will say, as you read all these items that you're asking about for symptoms of ADHD, I find I have those problems. And I was never identified as having these problems, but I still have them in my work. And there's another variant of this too, and that is menopause. Uh, I've published with my colleague Neil Epperson, Epperson, uh, 3 studies in the medical journals about research that we have done with menopausal women, because I was getting parents coming in and saying, I'm talking about women now who are, 45, 55 years old. They're bringing in teenage kids, and they're listening to the list of symptoms as I read it to evaluate the kid. And many of these business and professional women would say, I did not have these problems when I was younger and in school, but more recently, I've had a lot more difficulty with my short-term memory and with other things that that are on your list for ADHD. And after I'd encountered several of these women with this thing, I'd never had it before, but I seem to be getting something like this now. Often they were frightened because they were thinking either I had ADHD and nobody noticed it, or uh, maybe I'm having early signs of dementia. But the fact is that estrogen is one of the primary modulators for the release of dopamine in the female brain. And when the estrogen level goes down, as it does during menopause, then that can exacerbate problems that were not a big problem before. And what we have demonstrated in the 3 papers we've published is that medicines used for treating ADHD can be used for helping women with midlife onset of ADHD symptoms that resemble ADHD, even though the person doesn't have the usual history of those problems until they hit menopause.
Okay, thank you. Thank you very much. We have run out of time, and I
Well, I
think we
thank
should
you for
stop.
your hospitality and for the patience of people listening.
Okay,
I
thank
feel
you.
honored to be able to talk with you, and I wish you uh, a good day.
Okay, hopefully see you soon.
I hope
Uh,
so. Thank you very much.
thank you.
Bye
Okay,
bye.
bye bye. Bye bye.